we will now discuss about etiology of preeclampsia. So, under etiology, we have four important theories to be discussed. Under four headings we will discuss this. They are: number 1, abnormal trophoblastic invasion. Abnormal trophoblastic invasion. Number 2, immunological factors. Okay. Number 3, maternal maladaptation. Maternal maladaptation. Number 4, genetic factors. Okay. Abnormal trophoblastic invasion, immunological factors, maternal maladaptation and genetic factors. So, under abnormal trophoblastic invasion, we need to know something. In the placental implantation and villi formation, we have something called primary villi, secondary villi and tertiary villi. You all know that a blastocyst has an outer trophoblastic layer, and in turn this outer trophoblastic layer is divided into syncytial trophoblast and the cytotrophoblast. Syncytial is the outer layer and cyto is the inner layer, within which we have the inner cell mass. The inner cell mass develops into the fetus, and the syncytial and cyto develop into the placenta or the chorion. Now, when villi formation occurs, say this is the syncytial trophoblast, which is the outer layer. Within the syncytial trophoblast, we have empty spaces called lacuna. Okay. This is the syncytial trophoblast, and within the syncytial trophoblast, we form empty spaces called lacuna. So, what is the importance of this empty spaces? Into these empty spaces or the lacuna, the maternal spiral artery empties its blood. Okay. So, say this is the spiral artery. The spiral artery empties its blood into these lacuna. Now, beneath the syncytial trophoblast, we have the cytotrophoblast. Now, what happens? These cytotrophoblasts enter the syncytial trophoblast and give finger-like projections into the syncytial trophoblast like this. Okay. They give finger-like projections into the syncytial trophoblast, and this is how forms a primary villi. A primary villi is syncytial plus cytotrophoblast. Okay. So, next what happens? Beneath the cytotrophoblast, you have the inner cell mass. Now, inner cell mass gives finger-like projections into the cytotrophoblast to convert this primary villi into a secondary villi. So, secondary villi is syncytial plus cyto plus inner cell mass, and now when fetal blood vessels enter these primary villi, these become tertiary villi. So, tertiary villi are nothing but secondary villi plus fetal blood vessels. Okay. So, this is a tertiary villi. Okay. So, now what we need to know is, see here we have spiral arteries, and in turn the spiral artery is lined by a single layer of endothelium. Okay. Say this is your spiral artery. Okay. This spiral artery is lined by a single layer of endothelium. Okay. Now, what happens? This endothelium of the spiral artery, now zoom this area and see, you will have the spiral artery here, and this is the lining endothelium of the spiral artery. Okay. And this is, say, the lacuna. Okay. and outside the lacuna you have the cytotrophoblast. Okay, say this is the cytotrophoblast. Now what should happen? This cytotrophoblast not only invades the syncytial trophoblast and forms villi or villus-like projection, but also this penetrates the lacuna and now it replaces the endothelium of the spiral artery. So, supposing the spiral artery endothelium is like this syncytial trophoblast now replaces the endothelium of the spiral artery with itself. So, the endothelium now is lined by cytotrophoblast. Okay, this is what is called as remodeling. Okay, remodeling. Fine. And the next is, remember, if supposing this is the lacuna, okay, this is the lacuna. Normally in the first trimester, the penetration of lacuna, I mean spiral arteries into the lacuna is only superficial like this. Okay. So, whichever segment has penetrated into the lacuna only gets remodeled. Now, what happens with advancing gestation? More and more spiral artery penetrates the lacuna and the spiral artery now goes deep into the lacuna. Okay. And because of this, more and more segment of the spiral artery gets remodeled. Okay. So, more the penetration, more the remodeling, that is how it goes. So, this superficial penetration occurs in the first trimester and we call this as first wave trophoblastic invasion. Okay, we call it as first wave trophoblastic invasion. Okay. So, when does the deep penetration occur? Deep penetration occurs only in the second trimester and we call this as second wave trophoblastic invasion. Okay, we call this as second wave trophoblastic invasion. Okay, so we have first wave trophoblastic invasion, we also have second wave trophoblastic invasion. So, when will the remodeling be complete? Only after the second wave trophoblastic invasion. In case the second wave trophoblastic invasion fails, penetration fails, deep penetration fails and remodeling also fails. Okay. So, this is the pathology, key pathology behind preeclampsia. So, what is the use of this remodeling? After remodeling, the vessel becomes a low resistance vessel. So, once remodeling occurs, the vessel becomes a low resistance vessel. So, now if second wave trophoblastic invasion fails, okay, failure of second wave trophoblastic invasion, okay, failure of remodeling, okay. So, resistance fails to drop, so high resistance and vasospasm. Okay, so this is the key word that you have to remember, high resistance and more importantly you have to remember this word vasospasm. Okay, this increases the blood pressure. Okay, so this is what the theory of abnormal trophoblastic invasion or abnormal placentation say. Okay, so next is what? Immunological factors. So I told you 4 factors in the beginning. Abnormal trophoblastic invasion, second is immunological, third is maternal maladaptation and fourth is genetic factors. Okay. So, second is immunological factors. So, what is immunological factor? Immunological factor, see, immunological factor says that all pregnancies have both maternal and paternal antigens. So, in the placenta you have maternal antigen, you also have paternal antigen. Now, because you have a foreign antigen called paternal antigen in the placenta, mother can adversely react to this foreign antigen, the paternal antigen. Okay. The mother can produce antibodies against this foreign antigen, that is the paternal antigen, and therefore reject the fetus. It can either lead to abortion if it happens in the early pregnancy, or if it happens in the late pregnancy, this can lead to vessel wall injury. That means this immune reaction, antibody mediated immune reaction, can lead to vessel wall injury and thereby vasospasm. So you understand that the key pathology behind hypertension is vasospasm. Now how does a normal pregnancy escape from this? A normal pregnancy escapes from this kind of a vasospasm, immune mediated reaction, because there is something called blocking antibody which protects the placental tissue, the paternal antigens, from getting exposed to, or it protects the mother from developing these antibodies against the foreign antigens, okay, blocking antibody, okay. So now what happens if the mother fails to develop this blocking antibody, okay, if the mother fails to develop this blocking antibody, that is where the immune reaction occurs, vessel wall injury occurs, vasospasm and ultimately hypertension. So this is what the immunological factor has to say. Next is maternal maladaptation, okay, maternal maladaptation. Now what, as I already explained to you about T helper 1 and T helper 2 in physiological changes of pregnancy, I told you T helper 1 produces pro-inflammatory cytokines, okay. T helper 2 produces anti-inflammatory cytokines, okay. Now a normal pregnancy escapes from rejection because there is conversion of T helper 1 to T helper 2, and pregnancy is a state where predominantly you see T helper 2 cells, okay. Now what if this conversion fails and if the T helper 1 cells predominate? That is where pro-inflammatory cytokines increase, and these pro-inflammatory cytokines like interferon and tumor necrosis factor, okay, interferons and tumor necrosis factor, they will provoke an immune reaction and aid in the rejection and vasospasm, okay. So this is behind maternal maladaptation. So I have told you about abnormal trophoblastic invasion. The second is immunological factors, the third is maternal maladaptation, and now the fourth one will be genetic factors, okay. So if you ask me, does it run in the family, does preeclampsia run in the family? Answer is yes, preeclampsia can run in the family. It has a genetic predisposition. So what are the genes involved in the pathogenesis of preeclampsia? The genes involved in pathogenesis of preeclampsia are: number 1, methylene tetrahydrofolate reductase gene, methylene tetrahydrofolate reductase gene. Number 2, factor 5 lead-in mutation, okay, factor 5 lead-in mutation. Number 3, HLA genes, okay. Number 4, nitric oxide synthase, NOS3, nitric oxide synthase, okay. Number 5, angiotensinogen, okay, angiotensinogen genes. Number 6, angiotensin converting enzyme genes. Number 7, lipoprotein lipase. Lipoprotein lipase, okay. So whatever we are discussing now may sound theoretical for you, but AIIMS aspirants, please understand that these are some target areas where new questions might come from, okay. So what are the genetic factors, genes involved in it? Methylene tetrahydrofolate reductase gene, factor 5 lead-in mutation, HLA, ACE and angiotensinogen, nitric oxide synthase and lipoprotein lipase. These are the genes involved in the pathogenesis of preeclampsia, and preeclampsia definitely has a genetic predisposition, okay. So last and final here, oxidative stress. If the lady is in oxidative stress, there is increased production of reactive oxygen species, okay, that in turn leads to vessel wall injury and vasospasm. So again I am telling, The key pathology is vasospasm. The mechanisms behind this vasospasm may be different, but the key pathology is failure to relax and vasospasm. Okay. So, these are the 4 important factors under the etiology. Now, we will discuss something about the markers or the substances involved in the pathogenesis of preeclampsia, the promising markers which can be used as predictors in future. Okay. So, what are the substances altered here? The substances altered in preeclampsia or the markers of preeclampsia. There are many substances which either increase or decrease in a woman who are at risk for preeclampsia, and they are substances which increase. I will tell you the substances which increase first. They are number 1, theca lutein cyst. Theca lutein cyst. I already discussed about this theca lutein cyst in one other topic, and there I told you theca lutein cysts are secretory in nature. Theca lutein cysts can secrete androgens, they can cause virilization, and also remember theca lutein cysts are seen commonly in gestational trophoblastic diseases, but theca lutein cyst can also be seen in any condition where there is a high HCG. Okay. Any condition associated with high HCG levels are at risk for developing theca lutein cyst. Okay. So, HCG itself is actually a marker for preeclampsia. So, high levels of HCG, and in turn theca lutein cysts are factors that will increase the chance of preeclampsia. Okay. Next is growth hormone. Growth hormone increases the risk of, high levels of growth hormone increases the risk of preeclampsia. Next is a very important substance called soluble FMS like tyrosine kinase. Soluble FMS like tyrosine kinase. What does it do, the soluble FMS like tyrosine kinase? It decreases the VEGF levels. Okay, soluble FMS like tyrosine kinase, it decreases the VEGF levels and therefore acts as a very important marker of preeclampsia. Okay. Next is leptin. Okay. Next is endothelin. Endothelin is a vasoconstrictor which again is increased in preeclampsia. Okay. Next is soluble endoglin. Soluble endoglin. Okay. Next, cardiac troponin. Cardiac troponin. Next is D-dimer, elevated levels of D-dimer. Okay. Next is increased consumption of factor 8. Next is fibrinopeptides A and B. Increased levels of fibrinopeptides A and B. Okay. Next is increased levels of atrial natriuretic peptide and brain natriuretic peptide. Okay. I already told you this point under physiological changes of pregnancy. Atrial natriuretic peptide and brain natriuretic peptide are not much altered in normal pregnancy, but those pregnancies which are destined to develop preeclampsia in future, these peptides are elevated. Okay. So, I am repeating, the substances or markers that increase with the preeclampsia, they are theca lutein cyst, HCG levels, growth hormone, soluble FMS like tyrosine kinase, leptin, endothelin, soluble endoglin, cardiac troponin, D-dimer, increased consumption of factor 8, fibrinopeptides A and B, and atrial and brain natriuretic peptide. Out of which, what are the MCQ points? Okay. Those which are likely to come in the MCQ are very important. Soluble FMS like tyrosine kinase. Okay. Very important. Soluble FMS like tyrosine kinase. And then soluble endoglin. Soluble endoglin. Two important things. Endothelin also possibly you can remember, but these two you have to definitely remember. Okay. Soluble FMS like tyrosine kinase and soluble endoglin. Okay. These are substances which increase with the preeclampsia. We will discuss also substances that decrease, okay, substances that decrease, okay. A decrease in prostaglandin, I2, a decrease in prostaglandin I2, thereby decreasing the ratio between PGI2 and thromboxane A2, decrease in the ratio between PGI2 and thromboxane A2. Next is a decrease in the refractoriness to angiotensin. Normally, normal pregnancies are refractory to pressor agents, they do not respond to pressor agents much, whereas pregnancies that are destined to develop a preeclampsia are conditions where this refractoriness is lost. Okay, so they start reacting to all vasopressor agents, and one such vasopressor agent is angiotensin 2, to which abnormally these pregnancies react. Okay, so increase in blood pressure. Okay, so next is a decrease in nitric oxide. Nitric oxide, as you all know, is a vasodilator, and nitric oxide is the main substance that regulates the placental blood flow. Okay, so decrease in nitric oxide, decrease in vascular endothelial growth factor, decrease in platelet induced growth factor. Okay, so decrease in prostaglandin I2, decreased refractoriness to angiotensin 2, decrease in nitric oxide levels, VEGF and PIGF. Okay, so these are the substances or markers that are promising predictors in the future. Okay. Next, two important things apart from this you need to know. One is hyperuricemia and hypocalciuria. Okay, hyperuricemia and hypocalciuria. Okay, excessive excretion of calcium, excessive uric acid levels in the serum or decreased excretion of calcium in the urine, both of them act as markers of preeclampsia. Okay, they act as markers of preeclampsia. So these are the substances which are altered in the pathogenesis of preeclampsia. Increase in certain substances whichever we have written in green, and decrease in certain things whichever we have written in orange.